Welcome to the RadOnc Smart Review Head and Neck Cancer series.
We are jumping right into a really critical topic today, one that really separates the foundational understanding of head and neck oncology. We're talking oral cavity 1.
Right. And this is all about mastering the clinical decision pathway. So we'll cover subsites, the huge role of depth of invasion, and, why surgery usually wins for this disease.
That is the single most important lesson. You have to internalize it immediately. For the oral cavity, the primary treatment paradigm is surgical resection.
Yeah, and if you compare that to the oropharynx, it's just a totally different world.
Totally different. In the oropharynx, you're thinking definitive chemoradiation is the standard, especially for that P16 positive disease.
So for us, the radiation oncologists, our role here is almost entirely adjuvant. It's all driven by what comes back in that final pathology report.
Absolutely, and that's why this is so high yield for your written exams, for your oral boards, because it forces you to understand anatomy, apply the modern staging, the AJCC 8th edition, and, most critically, know exactly when to pull the trigger on those adjuvant treatments.
If you miss the primary treatment choice here, or you mess up the staging, your whole management plan just completely falls apart.
It really does.
Okay, so let's anchor this whole discussion with a case, a pretty classic one. We have a 58-year-old man. He comes in with a painful ulcer on the right lateral side of his tongue that just won't heal.
And he's got the big risk factors.
Oh, yeah, a 40-pack year smoking history. And he tells you he drinks alcohol every day. The tumor, clinically, measures about 2.5 centimeters, and the biopsy confirms squamous cell carcinoma.
So on the exam and the MRI, you see that 2.3 centimeter surface dimension. But, and this is the crucial piece of information, the thing that drives the T-stage now is the depth of invasion, the DOI.
And what's the DOI?
It's measured at 11 millimeters. Clinically, his neck is totally clear. He's N0.
Okay, so a lateralized oral tongue cancer. It looks kind of small on the surface, but that DOI, 11 millimeters, tells you it's biologically aggressive, and he's clinically node negative.
Right. So this immediately sets up the 4 key questions we have to answer.
4 questions that really structure the whole plan. So, 1, what is the clinical stage? 2, what's the primary definitive treatment you'd recommend?
3, how are we going to manage the neck, which right now is N0?
Yeah.
And then finally, 4, when do we, the radiation oncologists, actually get involved?
We're going to answer every single one of those, starting with, the most critical concept at all of head and neck cancer.
Getting the anatomy right.
The crucial boundary. So if you're presented with a tongue tumor, your first reflex, your immediate question, has to be about its position relative to the fodder.
The circumvallate papillae. That line is everything.
It really is.
It's the defining landmark. It's like the great divide in head and neck oncology.
Yeah.
Everything anterior to that line, the taste buds transition, that's the oral cavity.
So that includes the lips, the buccal mucosa, the alveolar ridges.
Right. The retromolar trigone, that little triangle of space behind the last molar, the hard palate, floor of mouth, and the oral tongue, which is just the anterior 2/3.
And the second you cross that line posterior to the circumvallate papillae, you're in a totally different zip code.
You are squarely in the oropharynx, and that's the base of tongue, the soft palate, the tonsils, and the posterior pharyngeal wall. And this isn't just academic. This anatomical line dictates everything.
Everything.
So why does it matter so much? I think there are 3 non-negotiable reasons that just completely change our approach.
Okay, reason number 1 has to be HPV status, the biology of the tumor.
Exactly. In the oropharynx, especially the tonsil and base of tongue, most of the cancer is HPV-driven. You detect that with P16 positivity, and that status gives a much, much better prognosis.
Right, which might lead to de-intensified treatments down the line.
But oral cavity cancer, it follows that old-school aggressive pathway. It is not HPV-driven, and this is a keyboard pearl. If you happen to find a P16 positive oral tongue cancer, it does not change the prognosis, and it does not change the aggressive management plan.
Okay, so that's a huge distinction. What's reason number 2?
Well, it flows right from the first one. It's the treatment paradigm. We've said it, but it's worth repeating. Oropharynx, especially advanced P16 positive disease, is often managed with definitive chemoradiation.
But oral cavity cancer.
It's surgery first. That's the default. It's accessible and you want to get it out.
And reason number 3.
Staging. The oral cavity is now staged using the AJCC 8th edition rules, where DOI is king. The oropharynx uses completely separate staging systems, one for P16 positive and another for P16 negative.
So if you get the subsite wrong, you use the wrong staging rules and your entire plan is incorrect from the start.
It's an instant fail. So if an examiner says you have a 2-centimeter tongue tumor, your immediate reflexive question must be,
Is that tumor anterior or posterior to the circumvallate papillae?
exactly. And our patient with a tumor on the lateral oral tongue is clearly defined as oral cavity. And his risk factors, that heavy smoking daily alcohol, that lines up perfectly with the traditional aggressive non-HPV-SCC.
Okay, so let's move to the neck, because that 11 mm DOI immediately raises some serious red flags about nodal risk, right?
Huge red flags. So you have to know the lymphatic drainage patterns cold. It dictates how you're going to manage this clinically N0 neck.
And for our patient's specific subsite, the oral tongue. That's the most common one. What's the first echelon drainage?
For oral tongue, it's levels 1, 2, and 3. And you have to know this subsite has a notoriously high risk of occult nodal metastasis, even when the neck feels totally clean on exam.
Which is exactly why that DOI measurement is so vital.
Right. Now, if we look at the floor of mouth, it's a bit different. It's constrained by the mandible, so its drainage is typically levels 1 and 2. The worry there is more about early mandibular invasion.
What about other anterior sites, like the buccal mucosa?
Also primarily levels 1 and 2.
And as you move further back?
So the retromolar trigone, that's a tricky spot. It drains to levels 2 and 3, reflecting that more posterior position, closer to the oropharynx.
And then something like the mucosal lip.
Oh, that's often treated almost like a skin cancer. It drains pretty much just to level 1, the submental and submandibular nodes.
So the key nodal map call-out here is that the oral tongue is a bit unique because it includes level 3 in that first echelon drainage.
It is, and remember, for any tumors that are midline or crossing the midline, like on the floor of mouth, you have to worry about contralateral risk. But our case is nicely lateralized, so we can focus on an ipsilateral approach to levels 1, 2, and 3.
Perfect. Let's transition now into the workup and staging, because this is where we really start putting the plan into action for our patient.
Okay, so you always start with the minimum required workup. That means a good physical exam and endoscopy, the biopsy to confirm it, and for looking for distant disease, a CT scan of the chest.
And with a heavy smoker and drinker like this patient, you're also looking for second primaries, right? In the lung or esophagus.
You have to rule them out. And critically, for anyone who might get radiation, you need a dental evaluation. It's absolutely mandatory.
Why is that so important?
To mitigate the risk of late toxicity, specifically ORN, osteoradionecrosis, you need that clearance letter from the dentist saying all the necessary extractions are done before you even think about starting treatment.
Okay, what about imaging for the primary tumor itself?
This is a bit nuanced. We primarily use MRI, magnetic resonance imaging, because it gives you superior soft tissue contrast. It's essential for accurately measuring the DOI and seeing if it's getting into the tongue muscles or the mandible.
And for distant staging?
For distant staging, we typically use a PET-CT. But a good quality CT of the neck with contrast is still the standard for just looking at the nodes.
Okay, so let's really drill down on the most important concept here. Depth of invasion, or DOI. Before the AJCC 8th edition, this wasn't really a thing, was it?
Not for staging, no.
Yeah.
T-staging was just based on the surface size. A 2-centimeter tumor was a T1, period.
Which we now know led to some serious undertreatment of aggressive tumors that just happened to be small on the surface.
It completely failed to capture the biology of the tumor. You could have a tumor that's like a puddle, thin, superficial, but 2 centimeters wide, or you could have one that's a deep, narrow well, only 1.5 centimeters wide, but it's pushing 11 millimeters deep into the muscle.
And that deep well, that's the one that's really dangerous.
It's way more dangerous because it's breached the protective layers and it's getting into the muscle where all the lymphatics and blood vessels are. That dramatically increases the risk of occult metastasis.
Which is why our patient's 11 millimeter DOI is so concerning.
And this whole shift was driven by really robust evidence. There was a landmark multi-center study by Iori, Abra, Hime, back in 2014. They looked at thousands of patients.
And what did they find?
They unequivocally proved that DOI is an independent predictor of both nodal metastasis and overall survival. It was more important than the surface size.
And that study gave us the critical cut points we have to memorize for staging, right?
Yes. 5 millimeters and 10 millimeters. This defines your entire risk ladder.
So if the DOI is less than or equal to 5 millimeters, you're in a favorable risk group.
Right. If it's between 5 and 10 millimeters, that's intermediate risk. And if it's greater than 10 millimeters, like in our case, that predicts the worst outcomes. The occult nodal rates start approaching 30% or even higher.
Okay, so with that, we can now officially stage our patient using the AJCC 8th edition rules. Let's walk through this because you have to have this down cold.
Let's do it. So T1. The tumor has to be 2 centimeters or less, and the DOI has to be 5 millimeters or less. Both criteria must be met.
So if you have a 2-centimeter tumor, but the DOI is 6 millimeters, it's not a T1.
Instantly fails T1. It gets upstaged.
Okay, what about T2?
T2 is this big intermediate zone. Your T2 if the tumor is 2 centimeters or less, but the DOI is greater than 5 millimeters. Or if the tumor is bigger, so greater than 2 up to 4 centimeters, but the DOI is still 10 millimeters or less.
Those for either intermediate size or intermediate depth.
Exactly. Then you get to T3. This is the high-risk category. You get here one of two ways. Either the tumor is big, greater than 4 centimeters on the surface, or the DOI is really deep, greater than 10 millimeters.
And finally, T4A.
T4 means the tumor is locally advanced and invading into adjacent structures. Things like cortical bone, the extrinsic tongue muscles, that's the genioglossus, hyoglossus, palatoglossus, and styloglossus, the maxillary sinus, or the skin of the face.
Okay, let's apply that framework directly to our patient. His tumor is 2.3 centimeters on the surface. By size alone, that sounds like a T2.
It does, but his DOI is 11 millimeters.
And according to the rules, a DOI greater than 10 millimeters is the dominant factor.
It is. It automatically pushes this tumor into the T3 category. So our patient has a T3N0M0 stage 3 oral cavity cancer.
Perfect. So this is the point where you need to be able to present the case comprehensively for your boards. Let's practice that 60-second board script verbatim.
Okay, let's hear it.
Examining. This is a 58-year-old man with a 2.3 centimeter squamous cell carcinoma of the right lateral oral tongue with depth of invasion of 11 millimeters, making this a T3N0M0, stage 3 oral cavity cancer. He requires complete staging with a CT scan of the chest and a mandatory dental evaluation.
Examining. The primary treatment is surgical resection with ipsilateral selective neck dissection of levels 1 through 3. Elective neck dissection is indicated given the depth of invasion exceeds 4 millimeters, which predicts significant occult nodal metastasis risk. The need for adjuvant radiation or chemoradiation will be determined by final pathology.
Examining. Specifically, we are looking for positive margins or extranodal extension as triggers for concurrent chemotherapy versus intermediate risk features like perineural invasion or close margins that would indicate radiation alone. If adjuvant therapy is needed, it should begin within 6 weeks of surgery to avoid prolonged treatment package time, which is associated with worse locoregional control. Long-term risks include osteoradionecrosis of the mandible, xerostomia, and dysphagia.
That's a fantastic script. It hits all the high points. Modern staging with DOI, the surgery-first paradigm, the evidence-based neck management, and all the key adjuvant triggers and timelines. It's robust.
Before we move on from staging, I want to bring up that early data from Ganley. They showed that if you had occult neck Mets disease you couldn't feel, your mortality increased 5-fold.
Yeah, and they also confirmed that a DOI greater than just 2 millimeters was an independent predictor of recurrence. That's why we start getting really nervous when the DOI hits 4 or 5 millimeters.
Right. So let's move to the next step. Pathology and molecular features. This is the section of the op report that tells us what to do next.
Exactly. So our histology is squamous cell carcinoma, moderately differentiated in this case. What we need to do now is clearly separate the intermediate risk factors from the absolute high-risk factors.
Because they lead to 2 totally different adjuvant treatments.
Completely different. Let's start with what we can call the 3 indicators, or the intermediate risk factors. These are the things that will trigger postoperative radiation therapy, or PORT, by itself.
Okay, so that list includes PNI.
Perineural invasion, so tumor cells tracking along the nerves. LVI, which is lymphovascular invasion tumor in the small vessels. And close margins, which we define as less than 5 millimeters from the ink.
And there are a few other intermediate triggers too, right?
There are. These also just get you PORT alone. So having multiple positive nodes without any E&E, having a pathologic T3 or T4 primary status, or finding any nodal disease in levels 4 or 5.
Okay, so that's the intermediate list. Then you have the big 2.
The big 2. These are the absolute non-negotiable triggers for combined modality therapy concurrent chemoradiation. These are the two features that the big trials identified as needing that extra systemic punch from chemotherapy.
And those are positive surgical margins, so tumor at the cut edge.
And ENE, or extranodal extension, where the tumor has broken out of the lymph node capsule. If you see either one of those, the prognosis gets much worse, and the patient immediately goes from radiation alone to concurrent chemorads.
Okay, one final point on pathology here. Let's just reiterate the P16HPV point one last time because it's such a common board trap.
It's a non-factor. It does not matter here. P16 positivity does not change the prognosis or the management in oral cavity SCC. The risk is all about the traditional factors: tobacco, alcohol, and the local invasion measured by DOI.
Perfect. So this brings us to clinical decision-making. Let's talk about why surgery is the primary treatment for oral cavity cancer and not definitive radiation.
Well, the advantages of surgery are pretty compelling. For one, it's anatomically accessible. The surgeon can usually get in there and get wide, clear margins, which is the cornerstone for controlling this disease.
And the reconstruction techniques now are pretty amazing.
They're very well established. You can use flaps and grafts to preserve function while still getting the whole tumor out.
But the other big reason is avoiding the toxicity of definitive radiation to that area.
Oh, absolutely. Giving a definitive dose, we're talking 70 gray to the whole oral cavity, that causes huge lifelong problems: severe mucositis, crippling dry mouth, trouble swallowing, and a really high risk of ORN.
So surgery front loads the morbidity, but the long-term function can be much better.
It's usually much better than if you'd given definitive radiation to that site.
Okay, so let's get back to the if-then risk ladder for the neck. How do we decide that our clinical N0 patient with an 11 millimeter DOI absolutely needs an elective neck dissection?
We rely entirely on that DOI threshold. The data shows that if the DOI is greater than 4 millimeters, the risk of having occult nodal metastasis crosses a critical line. It gets up to 20 to 30%.
And once you hit that level of risk, the benefit of clearing out those hidden mets up front outweighs the risks of the surgery.
Exactly. So an END becomes indicated, and in our case, 11 millimeters is way over that 4 millimeter cutoff, so the neck dissection is mandatory.
Since it's lateralized, we'd recommend an ipsilateral selective neck dissection of levels 1 through 3.
Correct. You can spare levels 4 and 5 unless you have some evidence of spread down there.
Okay, the second big clinical decision point is the timeline. You called it treatment package time. This is a common place to slip up in a busy clinic.
It is. You have to remember the classic work by Peters and his colleagues from MD Anderson. They showed that if the total time from the day of surgery to the last day of radiation hits 85 days or more, it's strongly associated with worse locoregional control and worse overall survival.
Wow. So the clock is really ticking.
The clock is ticking. The goal has to be to start your postoperative radiation therapy within 6 weeks of the surgery. Every week you delay erodes that benefit, especially for a fast-growing cancer like squamous cell.
Okay, let's just clearly summarize the adjuvant triggers from the NCCN pathway. The big two versus the intermediate list.
Simple. Chemoradiation is triggered by the two high-risk features: positive margins and ENE. The standard dose for that is typically 60 gray in 30 fractions, given with cisplatin.
And PORT alone, just radiation, is for that whole list of intermediate risk factors.
Right. Close margins: PNI, LVI, multiple positive nodes without ENE, a PT3 or PT4 primary, or nodes in levels 4 or 5.
Okay.
And the dose for PORT alone is the same: 60 gray in 30 fractions. Just no chemo.
Okay, let's get into the trials and evidence, the backbone for all of these rules.
This is how we know what we're doing saves lives. We're not just memorizing rules.
Let's start with the decrease trial. This one solidified the role of the elective neck dissection.
Yes. DCRUISE trial, New England Journal of Medicine, 2015. It was a randomized trial comparing elective neck dissection up front versus what they called therapeutic neck dissection, which basically meant watch and wait.
So wait until the nodes pop up, then operate.
Exactly. And they enrolled almost 600 patients with T1 to T2 lateralized oral cavity cancer.
And the results?
The waiting approach failed dramatically. Elective neck dissection significantly improved 3-year overall survival from 67.5% to 80%.
Wow, that's a 12.5% absolute survival benefit. That's huge.
It's massive. And the disease-free survival jumped from about 46% to almost 70%. The takeaway is crystal clear. Being proactive in the neck saves lives. This is the Category 1 evidence supporting that 4 mm DOI cut point.
Okay, next up, the twin trials that gave us our adjuvant chemo rules. RTOG 9501 and EORTC 22931.
Right. These two big trials independently looked at adding concurrent cisplatin to post-op radiation in high-risk head and neck patients. And the pooled analysis of both gave us the statistical power to really define the triggers.
And the outcome was pretty clear.
It was very clear. Only E&E and positive margins got a significant benefit from adding cisplatin. For the intermediate risk factors like PNI or close margins, adding chemo didn't improve survival, it just added toxicity.
So that's why E&E and positive margins remain our absolute Category 1 evidence triggers for concurrent chemorads.
Exactly. It guides our entire decision on whether to put a patient through the toxicity of cisplatin.
And we should probably briefly mention the OCAT trial.
Yeah, the OCAT trial was more recent, done in Asia. It tried to refine who benefits from chemo in just the oral cavity population. It didn't really change the board standard, but it suggested the benefit might be concentrated in a triple high-risk group.
So patients with T, 3 to 4, N, 2 to 3, and E&E.
Right. It just tells you that the biggest bang for your buck with chemo is in the most advanced cases.
Okay, let's pivot to the really practical stuff now. The treatment techniques and planning workshop. The patient is out of surgery. Now it's our turn.
Right. So the simulation setup has to be precise. Standard stuff. Supine position, thermoplastic mask, neck extended. But for oral cavity, you need some specific tools.
Like a tongue depressor or a custom bite block.
Yes, the bite block is key. You needed to displace the mobile tongue and the floor of mouth away from the hard palate. That separation is crucial to minimize dose to uninvolved tissues.
You might even use a custom dental stent to push the jaw away.
People do. All to minimize dose to the bone and spare the contralateral parotid. And critically, your simulation CT has to be fused with the preoperative MRI and the post-op CT so you know exactly where that tumor bed was.
Okay, let's define the risk-stratified CTVs, the clinical target volumes, and their doses. It's a 3-tier dose painting scheme.
Right. So the high-risk CTV, the area most likely to have residual disease, gets targeted to 60 to 66 gray. This covers the tumor bed, any areas of positive or close margins, and any nodal levels that had E&E.
Then you have the intermediate risk CTV.
That gets 54 to 60 gray. This covers the entire surgical bed, even with clear margins, and any positive nodes that didn't have E&E.
And finally, the elective CTV.
That's the prophylactic volume, covering the clinically negative neck levels. It gets a dose of 44 to 50 gray. For our patient, that would be levels 1, 2, and 3 on the ipsilateral side.
And what's the standard fractionation for all this?
It's 2 grays per fraction, delivered daily, Monday through Friday, usually 30 fractions for a 60 gray total dose.
So what are the big planning pitfalls here? The common mistakes that can lead to recurrence or terrible side effects?
The number one pitfall, I think, is not adequately covering the surgical bed. Specifically, missing the spot where there was a close or positive margin. This happens when you only look at the post-op CT and you don't fuse the pre-op imaging or read the op note carefully.
And the second big one.
The mandibular hotspot. The mandible is a critical organ at risk. If you create a focal high-dose region on that bone, you dramatically increase the risk of ORN.
So you have to be really strict with your dose constraints. Let's review those, starting with the mandible.
For the mandible, you have to minimize the volume getting 60 to 65 gray. You use IMRT to scoop dose away from it, and you must absolutely avoid hotspots greater than 70 gray.
What about the contralateral parotid? That's the gland we're trying to save for saliva.
The goal there is a mean dose less than 26 gray. That's the standard constraint that the data suggests will preserve at least some meaningful function.
And the spinal cord.
Max dose below 45 gray to prevent myelopathy. For the larynx, the mean dose should just be as low as you can possibly get it to reduce swelling and long-term swallowing problems.
Okay, let's circle back to our patient. The 58-year-old with the T3N0 DOI of 11 millimeters.
So he goes to surgery, gets his tumor removed, and an ipsilateral neck dissection. The final path comes back. Margins are clear, but he has PNI, and there are 2 positive nodes, both without E&E.
So what's the adjuvant plan now?
Well, P&I, 2 positive nodes, and that PT3 status, those are all intermediate risk factors. Since there's no ENE and no positive margin, he gets PORT alone.
So 60 grays and 30 fractions, and you spare him the chemotherapy.
Exactly. You avoid all that extra toxicity because he doesn't have the high-risk features. It just highlights how important that clean separation is.
Okay, now let's talk about preparing the patient for the inevitable side effects, toxicity management.
The big one for this part of the body is ORN, osteoradionecrosis of the mandible. It can be just devastating.
And the big risk factors we counsel patients on.
A mandibular dose over 60 grays, continuing to smoke, and the #1 clinical trigger, having teeth pulled after you've had radiation.
This is the mandatory clinical pearl. You have to hammer this home with your patients.
You really do. Pre-radiation therapy extractions prevent ORN. Post-radiation therapy extractions cause ORN. All dental work has to be done before radiation starts.
Okay, what about xerostomia or dry mouth?
Our best defense is a technical one. Sparing that contralateral parotid gland, aiming for that mean dose under 26 grays. If we can do that, we might be able to use meds like piloearpine to stimulate what's left.
And the acute toxicity is dominated by mucositis.
Oh yeah, you should expect grade 3 symptoms. So ulcers, severe pain, inability to swallow solids. Most of these patients will need a PEG tube.
And the key point is that you don't want to give them treatment breaks.
You strongly discourage them. Breaks lengthen the package time, and we know that's bad for outcomes. You have to manage the symptoms aggressively to keep them on schedule.
And finally, dysgeusia, or taste dysfunction.
It's incredibly common, and it really impacts quality of life. But it's important to reassure patients that partial recovery is the norm, usually starting around 6 to 12 months after treatment.
Okay, let's wrap this up by focusing on the 3 most common pitfalls, the oral board traps you have to avoid.
Let's do it. Misstep #1. Recommending definitive chemoradiation for a resectable oral cavity cancer.
The default answer is always surgery. If you recommend definitive radiation, you better have a good reason, like the patient is medically inoperable or they refuse.
Misstep #2, and this is a classic, staging by size alone and not asking about DOI.
If the examiner gives you a 2-centimeter tumor and you call it a T1 without asking, they're going to tell you the DOI is 11 millimeters and you've just staged a T3 as a T1. You have to ask for the DOI.
And misstep #3, using P16 status to assign a favorable prognosis in the oral cavity.
We've said it a few times, but it's that important. HPV biology applies to the oropharynx, not the oral cavity. Don't let P16 change your management here.
Okay, let's lock this all down with a quick, bold review.
Question 1. A 62-year-old woman has a 2-centimeter squamous cell carcinoma of the right oral tongue. MRI shows a depth of invasion of 8 millimeters. The neck is clean. What is the correct T stage?
The correct answer is T2.
And the rationale?
T1 requires the DOI to be 5 millimeters or less. 8 millimeters is over that. But T3 isn't triggered until the DOI is greater than 10 millimeters. So a 2-centimeter tumor with an 8-millimeter DOI falls right into that T2 category.
Perfect. Question 2. A 55-year-old man has a clinical T2 N0 floor of mouth cancer. He's otherwise healthy. What is the recommended primary treatment?
The answer has to be surgical resection with an ipsilateral elective neck dissection and then consideration of adjuvant therapy. Oral cavity cancer is a surgical disease, and a T2 lesion is almost certainly going to have a DOI greater than 4 millimeters, so the neck dissection is required.
Question 3. Which pathologic finding is an indication for adding concurrent chemotherapy to post-operative radiation? Is it P&I, pathologic T3 stage, ENE, or multiple nodes without ENE?
The answer is ENE, extranodal extension.
Right.
From the RTOG and EORTC trials, ENE and positive margins are the only 2 Category 1 evidence triggers for chemoradiation. Everything else on that list is an intermediate risk factor and would just get PORT alone.
Final question. Question 4. A patient finished surgery for an oral tongue cancer 7 weeks ago. The path showed a PT3N1 with 1 node showing ENE margins were negative. What's the most accurate statement about management?
The most accurate statement is that chemoradiation is indicated and it should start immediately because that 7-week delay is already suboptimal. The ENE is the absolute trigger for chemoradiation, even with negative margins. And the 7-week delay is pushing that treatment package time close to the 85-day limit, which we know hurts outcomes.
Excellent. Let's finish this up with our clinical pearls, the high-yield takeaways you need to walk away with.
Pearl 1. Oral cavity is a surgical disease. This is the foundational paradigm. You have to know that radiation is adjuvant and driven by pathology.
Pearl 2. DOI changes T-stage in AJCC 8th edition. Remember the two cut points, 5 millimeters and 10 millimeters? If you don't stage with DOI, you're underestimating the tumor.
And Pearl 3. Positive margin, or E&E, triggers chemoradiation. Everything else triggers PORT alone. That's the simplest way to apply all that trial data to any post-op patient.
So in summary, we define the oral cavity using the circumvallate papillae. We established that AJCC 8th edition staging is driven by DOI, and we confirmed that surgery plus elective neck dissection is the standard approach.
And we detailed how adjuvant therapy is guided by specific pathology triggers, while stressing how important it is to manage that treatment package time and prevent ORN.
Complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next series. We're going to tackle the clinical dilemma of the node-negative neck in a lot more detail. Thanks for tuning in.